Hi everyone, and welcome back to the channel, Nurse Notes and Knowledge. Today we're breaking down hyperkalemia, a potentially life-threatening electrolyte imbalance that nurses need to recognize and act on quickly. This short video and guide will give you everything you need to know to understand, assess, and manage hyperkalemia confidently in your clinical practice. Let's get started. What is hyperkalemia? Hyperkalemia is when there's too much potassium in the blood, typically defined as a serum potassium level above 5.0 milliequivalents per liter. Small imbalances can cause major issues of this vital electrolyte, especially when it comes to the heart. So keep in mind, normal serum potassium range is narrow, and levels outside of range can be life-threatening. A serum potassium greater than 7 can cause a cardiac arrest. Remember, 97% of potassium is located within the cells and is most abundant in the GI tract. Functions of potassium include promotion of transmission and conduction of nerve impulses, as well as contraction of skeletal, cardiac, and smooth muscles. Potassium assists with acid-base balance, and it is involved with cellular metabolism. In terms of body involvement in pathophysiology, we can break causes down into three main categories: decreased excretion, cellular shift, and excess intake. In terms of decreased excretion, renal influence, overall decreased renal function, either acute or chronic renal failure, kidney failure is the #1 cause in decreased excretion. You also have potassium-sparing diuretics, for example, spironolactone and other medications to include ACE inhibitors and NSAIDs. Potassium-sparing medications promote retention, while ACE inhibitors cause decreased excretion. With cellular shifts, a state of acidosis, where hydrogen molecules shift into the cells, potassium shifts out of the cells. Major trauma, tissue damage, burns, crush injuries, and rhabdomyolysis, cellular death, and a state of pseudo-hyperkalemia, which can be a result of hemolyzed serum, even due to a tourniquet application. And lastly, excess intake, usually only problematic when kidneys are already impaired, or overuse of potassium supplements or salt substitutes high in potassium. Hyperkalemia can be sneaky. Some patients may show no symptoms at all until it's severe. Lab monitoring is crucial, especially in patients with kidney issues or patients that are on potassium-altering medications. Other signs and symptoms include the following: muscle weakness, which is an early sign progressing to paralysis starting in the legs, fatigue, nausea, abdominal cramping, hyperactive bowel sounds, and diarrhea. On an ECG, hyperkalemia causes peak T waves, which is an early sign, progressing to widened QRS complex, prolonged PR interval, loss of the P wave, ventricular fibrillation, and then asystole. Recognizing the signs and symptoms is critical to patient safety, as this electrolyte imbalance can turn life-threatening fast if signs and symptoms are missed. For this slide illustrates common manifestations of hyperkalemia, and I'll go through these quickly. We have dysrhythmias. This is the big danger. Muscle weakness, which is an early sign, progressing to flaccid paralysis, nausea, diarrhea, GI symptoms such as colic and hyperactive bowel sounds. Why is it so important to recognize hyperkalemia early? The main reason is that it can cause cardiac arrest. Unlike some conditions that take time to develop, hyperkalemia can progress quickly and silently with few early warning signs. One minute a patient may feel tired or weak, the next minute their heart rhythm becomes irregular, and without quick action it can stop altogether. As nurses, we're often first to see changes early, whether a subtle EKG change, muscle weakness, or lab value that's just slightly off. Severe hyperkalemia is considered a medical emergency and requires immediate intervention. The goal is to stabilize the heart, shift potassium back into the cells, and remove excess potassium. ECG findings will show the following: peaked T waves, widened QRS, loss of P wave, and ultimately will lead to cardiac arrest. This is why nurses must respond promptly. There are several methods to shift potassium back into the cells and remove excess potassium in the body. As far as IV therapeutic interventions, treatment depends on the serum levels and the presence or absence of ECG changes, and the patient's baseline renal function. If life-threatening ECG changes exist, there are some common IV interventions, and they include the following. Slowly administer 10% calcium chloride solution or 10% calcium gluconate IV. This intervention helps to protect cardiac cells from potassium-induced irritability. However, it does not lower potassium levels. Administer IV insulin and glucose to drive the potassium back into the cell. Follow your institutional guidelines, but you may give 1 ampule of D50W, 50 mL, and 10 units of regular insulin. Monitor serum glucose levels and observe the patient closely for hypoglycemia. Note this is a temporary measure to decrease the serum potassium levels. Consider sodium bicarbonate given IV slowly over 20 to 30 minutes. The onset of this is immediate and can last up to 1 to 2 hours. The action of the sodium bicarbonate helps shift potassium into the intercellular space by increasing the blood's pH. Also, if the patient has adequate renal function, consider lysis 40 to 80 milligrams and normal saline IV to promote diuresis and potassium loss. Administer Excretion either orally or by rectal enema. Please note onset of action is slow, making this drug a poor choice for initial treatment of life-threatening hyperkalemia. And lastly, hemodialysis, if potassium levels are life-threatening, especially in patients with renal failure who are unable to excrete excess potassium. Also, a point of consideration, verify that the blood specimen is not hemolyzed as a cause of a false hyperkalemia, also called a pseudo-hyperkalemia. So treatments and interventions: potassium restriction. Assess renal function. Specific labs to pay attention to include BUN, creatinine, as well as urinary output. Monitor and report any potassium levels greater than 5 milliequivalents per liter. Monitor daily urinary output, and output that's less than 250 mL in 8 hours. Monitor vital signs and ECG. This patient population should definitely be on a EKG monitor, and you would typically see this type of patient in a cardiac or step-down unit or ICU for close observation and monitoring. Nursing diagnoses and continued management. Always obtain a health history during your patient assessment. Assess for signs and symptoms of hyperkalemia. Check the patient's ECG for changes. Remember the hallmark changes of a peak T wave progressing to widening QRS, complex and prolonged PR interval. Obtain daily or serial potassium lab draws. Assess vital signs, urinary output, and be sure to report any abnormal findings. For nursing diagnoses, I've included 2. Number 1, risk for decreased cardiac output related to dysrhythmia secondary to hyperkalemia and impaired urinary elimination related to renal dysfunction and/or cardiac insufficiency. Clinical management. 3 key points to remember and consider for your daily practice. Number 1, successful clinical management of hyperkalemia requires immediate intervention. Secondly, confirm the cause for the potassium imbalance and that it was corrected. And thirdly, evaluate the effectiveness of the correction and make any necessary adjustments if needed. This next slide is a comparison of hyper and hypokalemia. The table includes the disorder, common causes, signs and symptoms, and treatment for each imbalance. And if you haven't checked out my other video on hypokalemia, that video is listed in my Electrolyte playlist, and you may want to check that one out. I will also leave a free PDF of this comparison in the description of this video below. Lastly, and most importantly, nurse responsibilities. What to focus on. Monitor labs regularly, especially in patients with renal disease and on potassium-altering medications. Recognize the signs early. Hold high potassium medications. Always advocate for your patient. educate your patients, and prepare for emergency interventions. Whether you're at the bedside, studying for exams, or preparing for clinicals, make hyperkalemia recognition a top priority. Thanks for watching, and if this helped boost your confidence, be sure to give it a thumbs up, drop a comment sharing your experience, and don't forget to subscribe for more nursing content. See you on the next one.